Good morning. I am Dr. Saurabh Piparsania. Today, I am going to discuss a topic on protein energy malnutrition. The topic would be covered under the following heads. What is the problem statement? How do we define protein energy malnutrition? What are the different indices to assess malnutrition in the community? How do we classify protein energy malnutrition? What are the clinical features of kwashiorkor, marasmus, marasmic kwashiorkor, and severe acute malnutrition? How do we manage a child with mild to moderate malnutrition? And what are the 10 steps of management of severe acute malnutrition, along with a special emphasis on the prevention of malnutrition in the community? So what is the problem statement? As we all know that malnutrition is pretty common in children below the age of 5 years. Early diagnosis and prompt management of such children can prevent long-term morbidity and mortality in these children. According to recent estimates, protein energy malnutrition accounts for approximately 35% of all deaths in children below the age of 5 years. So it is a significant number of deaths that can occur in children because of only protein energy malnutrition. It is also found that 11% of total global daily is caused by PEM. That is, disability adjusted life year is approximately 11%. According to the recent estimates by Nature Family Health Survey, approximately 40% of children in India below the age of 3 years are underweight, 45% are stunted, and 23% are wasted. These are the data from the Indian subcontinent. Now, what is PEM? PEM is cellular imbalance between the supply of nutrients and energy and the body's demand for them to ensure growth, development, and maintenance of specific function. It includes undernutrition and overnutrition. Undernutrition is inadequate consumption, poor absorption, or excessive loss of nutrients from the body. And overnutrition is overindulgence or excessive intake of excessive nutrients. So the term PEM includes both undernutrition and overnutrition, but in clinical practice and for all purposes, PEM is synonymous with undernutrition. So what are the various indicators we use to assess malnutrition in the community? Two anthropometric measurement, height, weight, and age of the child is very important in determining the malnutrition in the community. On the basis of this measurement, we identify child who are stunted, wasted, and underweight. Stunting is defined as low height for child's age and is an indicator of chronic malnutrition. Wasting is low weight for child's height and it is an indicator of acute malnutrition. And underweight is low weight for age and it is an indicator of combined acute or chronic malnutrition. Based on these anthropometric indices, various classification systems were used, but nowadays WHO and IP classification is commonly used to identify malnutrition in the community. WHO classification is based on weight for height and height for age measurement and presence or absence of edema. It recommends the use of Z score or SD score, that is standard deviation score. There are two categories of malnutrition as per WHO. These are moderate malnutrition and severe malnutrition. If there is no edema and the standard deviation score of the child for weight for height and height for age is between -2 to -3, child is classified as moderate malnutrition. But if bilateral pedal edema is present, child is automatically classified into severe malnutrition or edematous malnutrition. If weight for height of a child is between -2 to -3 standard deviation, it is moderate malnutrition. And when it is less than -3 SD score, it is severe malnutrition. Similarly, when height for age is between -2 to -3 standard deviation, it is moderate malnutrition. But if height for age SD score is less than -3, it indicates severe malnutrition. IP classification is based on weight for age values and the standard uses 50 centile of Howard. On the basis of weight for age and its percentage, child is classified into 4 grades. Normally, it is more than weight for age is normally more than 80%. Child is said to have grade 1 malnutrition or mild malnutrition when it is 71 to 80%. Grade 2 malnutrition or moderate malnutrition when weight for age is 61 to 70%. Grade 3 malnutrition or severe malnutrition when weight for age is 51 to 60%. And grade 4 malnutrition or very severe malnutrition when weight for age value is less than 50%. Certain age-independent indices were developed to assess malnutrition in the community, especially in those children who live in orphanage or those who are survival of natural calamities like flood, earthquake, or any other natural disaster, in whom in these children where the age cannot be identified, but to assess malnutrition in the community, certain indices were developed. These indices are mid-upper arm circumference. It is measured by measuring tape. The midpoint of oligoclinic and acromion process is taken, and it is measured in children between 6 months to 5 years of age. If it is more than 35%, 13.5 centimeters, it is considered to be normal. And if it is less than 13.5 centimeter, it is considered to be an indicator of malnutrition. For the use in community by ASHA worker and other healthcare workers, a color-coded tape or Shaki tape is used to determine mid-upper arm circumference. Second age-independent indices is Bengal test. A Bengal or a chudi of internal diameter of 4 centimeter is made to pass above the elbow. In normally nourished children, it doesn't go above the elbow, but in malnourished children, it usually goes above the elbow. Third is skin fold thickness. Certain types of calipers are used to measure skin fold thickness and certain ratios like Kanavati and McLaren index, Rao and Singh's index, Dugdale index, Quaker arm circumference measuring stick or Quack stick, and Jellyf ratio. These are the few age-independent indices that one must know. Now, what is the underlying cause of malnutrition? Poverty, it is the main culprit for the causation of malnutrition in the community. Because of poverty, the family cannot purchase a good diet or a diet that is rich in nutrition, leading to deprivation of nutrition among all the family members and leading to malnutrition. Second is inadequate maternal care during antenatal period, because when the mother's health is neglected, the fetus that is growing in the mother's womb is also neglected, and the mother may give birth to a baby who might be low birth weight or IUGR baby, who may develop malnutrition in coming years. Poor environment, that is lack of availability of potable water or drinking water, lack of good sanitation facilities may also lead to development of malnutrition, because the children living in this area are more prone to infection, and because of recurrent infection, they can develop malnutrition. And fourth is inadequate or lack of access to healthcare services may also promote malnutrition in the community. Clinical feature. On the basis of clinical feature, PEM is classified into mild malnutrition, moderate, and severe malnutrition. Malnutrition is common in children between the age of 9 months to 2 years. It is characterized by growth failure, that is slowing of linear growth, static or declining weight, decrease in mid-upper arm circumference, normal or diminished weight for height measurement. Children with mild malnutrition are more prone to develop infection, particularly of the gastrointestinal tract, and it often presents as loose motion or diarrhea. Pneumonia is very common, and child often have cough, cold, and fever requiring frequent visit to a clinician. And tuberculosis, because of low immunity, the children with PEM can develop tubercular infection as well. Mild to moderate degree of anemia is common in children with mild malnutrition, and activities often decrease. Moderate to severe malnutrition is classified into marasmus, kwashiorkor, marasmic kwashiorkor, and severe acute malnutrition. Now, marasmus, it is common in first 2 years of life and it results from prolonged starvation. The signs of marasmus are severe wasting, that is, child appears very thin, like skin and bones. They have monkey faces or old man's appearance because of the loss of buccal pad of fat. They have baggy pant appearance because of hanging of loose skins of the buttocks, resembling baggy pant. Child appears to be alert and have voracious appetite. This is a slide and picture showing a child with marasmus. You can very well appreciate old man's or monkey face appearance of the child. All the bones and ribcage are visible. Child is emaciated and looking very irritable. Kwashiorkor, it is common in children between 1 to 4 years of age. It is characterized by the presence of 4 essential features. These are growth retardation, where the weight for age is between 60 to 80%, muscle wasting with preservation of subcutaneous fat, psychomotor changes or mental changes that includes apathiness, listlessness, and lack of interest in the surroundings, pitting edema, that is, child appears healthy. Because of pitting edema and preservation of the subcutaneous fat, parents think that their child is healthy and they do not visit the nearest hospital or healthcare facility despite having severe malnutrition. Other features of kwashiorkor include fat or sugar baby appearance. Muscle is wasted. In this, child becomes weak, hypotonic, and unable to stand or walk. Child has characteristic skin changes, which are commonly seen on buttocks, perineum, and upper thigh. It includes flaky paint dermatosis, that is confluent pigmentation, and enamel paint dermatosis. These are the individual spots. Mucous membrane lesions are also common, and it includes tongue, leading to smoothness of the tongue, chelosis, and angular stomatitis. Hair changes may occur and are characterized by loss of curl. Hair become lusterless and are easily pluckable. Flaxen is seen in children with kwashiorkor. In this, alternate bands of hyperpigmented and normally pigmented hairs are seen, which indicates the period of undernutrition and normal nutrition. Anemia is common in child with kwashiorkor. GI changes can occur and includes anorexia, vomiting, abdominal distension, watery or semi-solid stools. Cardiovascular system involvement can also be seen in children with kwashiorkor and manifests as cold and pale extremities, decreased cardiac output, and hypotension. Renal impairment may occur in the form of reduced renal blood flow and reduced GFR. So virtually in kwashiorkor, any organ system of the body can be affected. This is the picture showing flaky paint dermatosis on the thigh and perineum of the child suffering from kwashiorkor. This is an important slide differentiating kwashiorkor and marasmus. These are the differentiating features. Marasmus is more common than kwashiorkor. Edema is absent in marasmus while it is present in kwashiorkor. Marasmic child is active while a child with kwashiorkor has apathetic look and has lack of interest in the surrounding. Marasmic child has a good and voracious appetite while child with kwashiorkor has poor appetite. Hepatomegaly is present in kwashiorkor but not in marasmus. Mortality is more in kwashiorkor and less in marasmus. Child with marasmus recovers early, while child with kwashiorkor has slow recovery, and marasmic child are less prone to infection as compared to the kwashiorkor. One of the reasons for these changes is because of the edema. Because the edema fluid acts as a good culture media for the bacteria to grow, leading to increased motility and increased chances of infection in child with kwashiorkor. Marasmic kwashiorkor, it is a mixed form of undernutrition. It manifests as edema with or without other signs of kwashiorkor and have varied features of marasmus. Now, this is very important, that is severe acute malnutrition or SAM. It is a special classification recommended by WHO to identify and manage children with life-threatening undernutrition. SAM is defined by WHO and UNICEF as presence of any of the following three criteria. These are weight for height when it is less than -3 standard deviation by WHO growth standard. Second is presence of bipedal edema. And third is when mid-upper arm circumference is less than 11.5 centimeter. So if any of these criteria is fulfilled, child is said to have severe acute malnutrition or SAM. Children with SAM usually have high risk of death and long-term morbidity. Now, how do we manage a child with PEM? Management mainly depends on severity. Mild to moderate case of PEM can be managed on ambulatory basis, and the mainstay of treatment in such cases is provision of adequate amount of proteins and energy to the child. In this, ensure that child receive at least 150 kcal per kg per day. For this, frequent feeding is often necessary. Ensure protein intake of 3 gram per kilogram per day with adequate amount of vitamins and minerals to be given to the child. These shall are called for regular follow-up and the best parameter to assess the success of treatment is weight gain. Management of SAM. WHO recommends exclusive inpatient management of SAM, though patients with SAM are classified into complicated and uncomplicated SAM, and uncomplicated SAM patients can be managed at home. For this, we have to assess severity by history and physical examination. In a child with SAM, look for the following complications. These are presence of severe edema or low appetite or failed appetite test, presence of any medical complications, and presence of one or more danger signs as per IMNCI. If any of these signs is present, child will have a complicated SAM. If none of the above feature is present, uncomplicated SAM is present and child can be managed at home under supervision. If any of the above is present, child is said to have complicated SAM and the child requires exclusive inpatient treatment. Supervised home management of child with uncomplicated SAM. It includes nutrition therapy, initially home-based food or RUTF, that is ready to use therapeutic food, is given to the child. Later, complete home-based food can be given along with continuing breastfeeding in children with uncomplicated SAM. The aim of therapy is to provide 175 kilocalorie per kg per day, and to provide this much amount of calorie, one has to feed child at least 6 to 8 times per day. Other treatment that are to be considered and given at home includes oral antibiotic amoxicillin at least for 5 days, mega dose of vitamin A, albendazole 400 mg in a single dose, and all the age-appropriate vaccines are to be given. Sensory stimulation is an important component of management of uncomplicated SAM at home, and it has to be given at home, and regular monitoring by healthcare worker. Children with complicated SAM are to be managed at hospital, and there are 10 steps which are to be followed for the management of such children. These 10 steps are treatment and prevention of hypoglycemia, treatment and prevention of hypothermia, treatment and prevention of dehydration, correction of the electrolyte imbalance, treatment and prevention of infection, correction of the macronutrient deficiency, initiation of the cautious feeding, attainment of the catch-up growth, provision of sensory stimulation and emotional support, and preparation of the child for follow-up after recovery. These 10 steps are uniformly followed at all hospitals and at all facilities where the children with SAMs are being admitted. These steps are accomplished in 2 phases, an initial stabilization phase and a longer rehabilitation phase. These steps 1 and 2, that is prevention and treatment of hypoglycemia and prevention and treatment of hypothermia. Whenever a child with SAM is admitted, measure blood glucose level, and if it is less than 54 If it is less than 54, then consider hypoglycemia. And if the provision for measuring blood glucose is not available, consider the child to be hypoglycemic and give 2 ml per kg of 10% dextrose and initiate feeding as soon as possible. Prevention and treatment of hypothermia can be done by skin-to-skin contact with parents, providing warmth to the baby, nursing in a drought-free area, providing warm blanket, avoiding exposure of this cold, and covering the baby properly by caps, socks, and mittens, and proper clothing. Third step is prevention and treatment of dehydration. Dehydration is difficult to be estimated in children with SAM. Assume some dehydration in children with watery diarrhea. Use dehydration solution for malnourished children, that is Resumal, with potassium potassium supplements for rehydration and maintenance. Initiate feeding with F75 diet within 2 to 3 hours of dehydration and prevent dehydration using Resumal solution and continuing breastfeeding. Fourth step is correction of the dyselectrolytemia or electrolyte imbalance. For this, give potassium supplement at a rate of 3 to 4 milliequivalent per kg per day for 2 weeks. Give Maxelf in a dose of 0.3 ml per kg intramuscularly on day 1. Thereafter, 0.8 milliequivalent per kg per day. And as these children with SAM have high sodium content, you have to prepare food without salt. We have to treat multiple infection because the infections are common in children with SAM. So begin treatment with parenteral ampicillin for at least 2 days and then switch over to oral amoxicillin for 5 days. If there is no improvement in clinical condition within 48 hours, switch the antibiotic to cefotaxime or ceftriaxone. Ensure that the child with SAM has received all the vaccine, and if not, give all the vaccines, and you have to follow standard precautions to prevent the spread of infection. Sixth step is the correction of the macronutrient deficiency, and WHO recommends the use of twice the recommended dietary allowance for the micronutrients and vitamins. Vitamin A is given on day 1 in a dose of 2 lakh international unit in children of the age of 1 year, 1 lakh international unit for children between 6 months to 12 months, and 50,000 international unit for children below the age of 6 months. Folic acid is given on day 1 in a dose of 5 mg, followed by 1 mg per day. The dose of zinc is 2 mg per kilogram per day. Copper is given in a dose of 0.2 to 0.3 mg per kilogram per day. Iron is given in a dose of 3 mg per kilogram per day only after the completion of stabilization phase. Seventh step is the initiation of feeding. Start feeding as soon as possible. Total fluid recommendation is 130 ml per kg per day, and it can be reduced to 100 ml per kg per day if the child is having severe edema. You have to continue breastfeeding. Initiate feeding with F75 diet every 2 hourly. That is, feed has to be given in night hours as well. If the child is having persistent diarrhea, give cereal-based low lactose F75 diet. So for initiation of the feeding, start with F75 diet, and if the child develops diarrhea or diarrhea is not stopped, give cereal-based low lactose F75 diet. Eighth step is the assessment of the catch-up growth. Once appetite returns in 2 to 3 days, increase volume of feeds and decrease frequency of feeds to 6 feeds per day. You have to continue with breastfeeding. Initiate F100 diet and increase calorie given to the child to 150 to 200 kilocalorie per kg per day and proteins to 4 to 6 gram per kg per day. And at this stage, you can also add other complementary foods as well. So once appetite has returned, in catch-up phase, you have to give F100 diet, and if the condition permits, you can add other complementary foods as well. Step 9 is the sensory stimulation, which is an important aspect in the management of child with SAM, because the children with malnutrition are often socially and emotionally deprived. So play and loving care and tender care can stimulate their intellectual and brain development. For this, structured play therapy and physical activity is started as soon as the child is well enough. A cheerful and stimulating environment is provided to increase the participation of the child. You have to encourage mothers and other family members' involvement in the caretaking of the child. Step 10 is prepare for follow-up. In this, child is said to a primary failure when he or she fails to regain appetite by day 4, failure to start losing edema on day 4, and if the edema persists on day 10, and failure to gain at least 5 gram per kilogram per day by day 10. Secondary failure to respond is said to be present when child fails to gain at least 5 gram per kilogram per day for consecutive days during the rehabilitation phase. This is the slide showing time frame for initiating and achieving 10 steps of SAM. Hypoglycemia and hypothermia and dehydration are to be corrected as soon as possible after admission, preferably within 1 and 2 days. Electrolytes are given from the day of admission till the completion of the rehabilitation phase, that is 6 weeks. Infections are to be controlled during the first 7 days. For this, give oral amoxicillin for first 2 days. Give intravenous amoxicillin for first 2 days and then oral amoxicillin for next 5 days. Macronutrients are given throughout the therapy, and iron is added only after 7th day of admission. Initially, feedings are started with F75 diet and then with F100 diet. Rebuilding of tissues occurs during the rehabilitation phase. Sensory stimulation is provided to the child throughout the therapy phase, and child is prepared for follow-up after the stabilization of the child. Death can occur in child in the setting of hypoglycemia, hypothermia, dehydration, infection, and severe anemia. So all these conditions must be looked for and treated aggressively and promptly, because delay in the identification and treatment of these conditions may lead to death of children with SAM. Criteria for discharge: when the child is alert and active, is receiving 120 to 130 kcal per kg per day with a pattern of consistent weight gain on exclusive oral feeds, when the child is receiving adequate micronutrients, when the child is free from infection, when child is immunized, and when the caretaker is sensitized for home care. So all these parameters are to be fulfilled before considering child to be a suitable candidate for getting discharged. A child can be discharged early, even before the recovery is complete, when the following criteria are fulfilled: when the age of the child is more than 12 months, he has a good appetite with satisfactory weight gain, has completed antibiotic treatment, and has taken macronutrient and multivitamins for 2 weeks. So when these 4 criteria are met, and if any condition warrants the child to be discharged before complete recovery, then he can be discharged. After discharge, few phenomena can be encountered during rehabilitation phase. These are pseudotumor cerebri, nutrition recovery syndrome, and encephalitis-like syndrome. Pseudotumor cerebri present with CNS manifestation, and it can occur in malnourished children following recovery. Nutrition recovery syndrome, it is commonly seen in children who are treated with very high protein diet. It presents as abdominal distension, increasing hepatomegaly, ascites, prominent thoracoabdominal veins, hypertrichosis, parotid swelling, and eosinophilia. Encephalitis-like syndrome is seen in 20% of patients with Kwashiorkor. Most often it is a self-limiting condition, and it is again due to too much of the protein in the diet. So one should be very familiar with these terms, because they can occur in child with SAM following recovery. Now, how can we prevent malnutrition in the community? It can be prevented at national level by National Nutrition Supplementation Program, nutrition surveillance, and nutrition planning. Prevention at community level can be done by providing health and nutrition education, by promotion of education and literacy in the community, because if the mother or one family members of the family members of the community are educated, it helps in improving their knowledge and improving the malnutrition in the community. Regular growth monitoring, family planning programs to limit the family size, and prevention at family level can be done by promoting exclusive breastfeeding till 6 months of age, initiation of the complementary feeds at 6 months of age, providing vaccination to prevent vaccine preventable disease, and ensuring adequate interval between two pregnancies. This is a slide showing diets for severely malnourished children. When the child has impaired liver and intestinal function along with infection, give food in a small amount through nasogastric tube or if possible orally. When the child is unable to tolerate usual amount of dietary protein, fat and sodium, diet low in above and high in carbohydrate is recommended. F75 diet is a diet that is given during the first 2 days after admission, and it provides 75 kilocalorie per 100 ml. F100 diet provides 100 kilocalorie per 100 ml. It has to be given every 4 to 5 hourly and ensure the child consumes 5 to 6 meals per day, and rehabilitation phase it is given. This is a slide showing composition of F75 and F100 diet. Thank you.